So I'd like to ask the last speaker. I would also like to remind you to think of questions, things you would like to ask to the speakers after the short break we will have. So it's my pleasure to introduce Lidia, and for once I will look for the presentation. It should be there. You found it already. So Lidia has come all the way from Australia to Belgium and has a lot of experience with cultural responsiveness, among other things, in healthcare. So the floor is yours, Lidia. You do need help.
Sorry. Thank you very much. Hi everyone. Luckily Hi everyone. Happily for you, I'm the final speaker this afternoon, so hopefully I can get through my presentation and we can move on to the panel discussion. I'm sure you'll have lots of questions from all the fabulous presentations so far. Okay, so I'm going to talk to you also about a framework and a whole of organisation approach that we've developed, but trying to look at some insights that we have for purchase on practice, so how it actually is being implemented at the moment. Just a little bit of context about my presentation. So firstly, just focusing on the what, the why, the what and the how. Talking a little bit about the framework called Partnering in Healthcare. It has 5 domains, it focuses on 3 levels, and I hope to provide some practical examples for you of how that's actually working currently. Ending on a little bit about what the future looks like and where we hope to go. Firstly, I just want to talk to you about a term that we use in Australia. We use the term consumer. Sometimes people don't like that term, it has different connotations. There are other terms like clients, patients, family members, carers, service users. So we use this term consumer because it's well known in Australia, and we use it to include all of those groups that I have just mentioned. So it's a very broad and inclusive term, and it's about including everyone in that. And that means it's about people who are current or potential users of healthcare. It also includes people who choose to get involved in decision making, so health consumer representatives, and they're people who provide advice, provide a lived experience perspective in organisational planning, design, review, service delivery, and again, as I said, many different types of health settings will use very different terms, but we include them all in the term consumer. I work for the Department of Health and Human Services in Victoria, so that's one of the most diverse states in Australia. So very similar to Canada, we have a very diverse population, a long history of migration, a long history of multicultural policies, some of which are better than others, and some, which certainly need improvement currently. But so one of the things that we always say in Victoria is, for us, diversity is the mainstream. But there's always a challenge in embedding that still in our policy and the way that we deliver healthcare. So my agency, part of the Department of Health and Human Services, is called Safer Care Victoria. So we were created out of a catastrophic failure of quality and safety in the Victorian healthcare system. So a small rural health service, very devastating results, a number of baby deaths that were not detected that could have been preventable. So we were created from a very terrible situation to look at how do we improve quality and safety across the healthcare system in Victoria. So our mission is outstanding healthcare for all Victorians, always. That's not to be compromised. And really, we are about enabling all health services, and we talk about health services, I mean hospitals, so primarily Victorian publicly funded hospitals, not private hospitals. So we are about working with health services to deliver safe, high quality care and experiences for patients, carers and staff. Since the creation of Safer Care Victoria, primarily I worked in the department prior to that, and I started to develop a partnering in healthcare framework before we transitioned into Safer Care Victoria. So this work continued, and it's as testament to the presentations earlier. This is a piece of work that has taken a considerable period of time to actually develop, to get off the ground, to actually co-design and to deliver together with consumers, and I'll talk a little bit more about that. But really, why did we need a framework? Well, we needed a framework because we had to really address the issue of equity in healthcare and to improve equity in treatment and care options for the very diverse Victorian population. We were really committed to reducing healthcare variation, so we know that not everybody has the same quality of healthcare, or that not everybody receives equitable healthcare, obviously. We needed to be more holistic and systematic. We needed actually to join up how equity and other issues and outcomes are addressed, not to treat them as silos, not to treat them as separate entities that have very little interaction. And we needed to ensure that equity is worked on collaboratively with service users, or as we call them, consumers. So we set about developing a co-design approach to create a new framework for the state of Victoria. So this framework applies to all Victorian public hospitals, all 88 of them. There's no exception. It is also relevant, however, for other funded types of agencies and services, such as community health, mental health community services, alcohol and drug, and public residential aged care services. It's also been adapted in other types of initiatives, such as responding to family violence situations with the creation of a similar kind of organisation called Family Safety Victoria. So its applicability is broad, and it can be adapted to different health-specific and community services contexts. Very briefly, this is the framework. It's called Partnering in Healthcare, and it comprises 5 interconnected domains. The first one is personalised and holistic, followed by working together, followed by shared decision-making, equity and inclusion, and effective communication. A note, firstly, equity permeates all of the 5 domains, even though we have actually isolated or signalled the importance of equity and inclusion as a clear domain in and of itself. But all of these domains cannot work separately, they can only work together. So I like to think of it as a clock going forward. You start with personalised and holistic healthcare. In order to achieve personalised and holistic healthcare, you can't actually achieve that if you don't have teams of clinicians, patients, consumers, staff members in hospitals working together to improve healthcare. You can't achieve personalised and holistic healthcare if you omit shared decision-making opportunities, or if you don't actually help people to be part of the decision-making process about their healthcare, about their treatment, about their values, what's important to them, and what they want as outcomes of their healthcare journey and experience. You can't achieve it again without attending to issues around equity and inclusion. And finally, of course, you can't achieve any of this without effective communication, attention to understanding health literacy, and all forms of communication opportunities. You might ask what this little tick is here, and that is an accreditation that we have received for this process and this document from our leading national consumers health organisation called the Consumers Health Forum of Australia. They give this accreditation tick to pieces of work or events where consumers are actually part of the design process and are partners in that particular journey. And we received that tick of accreditation because we co-designed this framework with consumers. And I'll talk a little bit about that in a moment. Very, very quickly, the 5 domains of the framework work at 3 different levels. Again, these 3 levels are always interconnected. So we like to talk about consumers partnering in healthcare at their own healthcare level. That is their direct care level or individual healthcare level. So what's actually happening to them? We talk about consumers partnering in healthcare at the service level, because consumers ought to be part of service level design, review, evaluation and improvement. They ought to be part of that process. Finally, they also ought to be involved at the system level. They should be on the board, the governance board of the health service. They should be part of our other structures of decision making at the absolute highest level. These things in Australia, as they are in many other countries, are supported by national accreditation frameworks. So hospitals have to be accredited against various criteria. One of the standards that we have in Australia is called Partnering with Consumers. So that's an accreditation standard which asks health services to provide evidence for how consumers are involved in various aspects of healthcare. Not only their own healthcare, but about improving healthcare with and for others. How is the framework developed? Very quickly, I've talked about a co-design approach. There are many terms which you've probably heard of: co-design, co-production, engagement, and a myriad of others. Now, many of these have lots of similarities, but they have points of difference. We chose the term co-design because it's part of the current healthcare lexicon in Australia. It doesn't mean it's perfect. It would be better if it was co-production, and that really means that you share power in decision making. I think we've still got a way to go to actually get there, but we just keep trying. So in terms of designing the framework, we actually asked people of Victoria what was most important to them and involved them in each phase of the development. So we designed a survey. We worked with a university who specialised in behaviour change theories and application. They helped us to construct an engagement strategy. It was conducted through an online platform. It's not the be-all and end-all. It's not the perfect consultation or engagement strategy, but it gave us incredible reach. We ended up with 3,000 comments, 180,000 site visits. So we had an opportunity to engage widely with a large range of people. For the first time, and this is one of the things that I think sets our framework apart, is that we actually employed a consumer as part of our team. So from the very start, and this really is the essence of co-design. If you can't actually involve consumers and service users at the start of doing any project for improving healthcare, you already are losing an opportunity for engagement. You're losing an opportunity for a strategy or an initiative or an intervention to actually be reflective of the needs and the voices of people that you're designing the work for. So in our team, we have a consumer who has lived experience. It's the first time in our area that we've done that. There are other areas and other precedents across Australia and across Victoria, particularly in the mental health area, in the mental health space, where they actually have lots of lived experience consumers involved. But this is the first time we did it. So our framework really is a result of a collective effort, and it's a collective product. And basically, it really is about saying, as an agency that has the capacity to develop a strategy, that we want to actually do that with people who the strategy is with and for. So it's really about that principle of nothing about us without us. Or had a previous policy in Victoria called not doing it with us for us, not doing it with us, but doing it, the other way around. Not doing it for us, but with us. Apologies. This just highlights very quickly our co-design process. So the consumer employed at the start, we used a Cochrane prioritisation methodology. We had a consultation which elicited many suggestions and comments. But basically we asked people, what would you do or how would you suggest we improve healthcare? We had a test framework that we had drafted, and this was validated through this process. We had a prioritisation summit where we actually wanted to hear much more from consumers, so we flipped the ratio. We had 2 consumers in the room compared to 1 health service provider. So the ratio was different. So the voices of consumers were the most important. From that, we drafted a framework. We tested that again with many stakeholder groups, health professionals, consumer groups and representatives. And we finally launched the framework in a forum in April this year. This is a graphic that was done at the forum in April, which reflects the concept of consumers transforming healthcare. So this is about shifting gears for real change, and it also echoes the voice of the Consumers Health Forum that I mentioned earlier, who gave us the accreditation tick. So this is talking about consumers or service users as co-designers of service. So not moving from the paternalistic approach that we have often had in healthcare, where things are done to patients, they're done to service users, they're done to people. This is about moving to a partnership and a genuine partnership approach where consumers, patients, service users are the experts about their own healthcare, about their own conditions and what they want to see improved and the way that they want to see that improved. This is just a snapshot of our forum. So one of the other things that we really believe in is actually making sure that as policy developers, we are actually putting into practice what we expect health services or hospitals to do. So for example, we sponsored 100 consumer places. So in 300 attendees, 100 people were consumers as part of the participation audience. 40 of those people had paid consumer roles to perform on the day. So they were social media ambassadors. They introduced sessions. They were chairs of sessions. They were roving connectors, connecting service providers and service users together throughout the day. Our framework is set out in such a way that we capture, importantly, what consumers said, so what they thought are the priorities in response to the questions from the consultation process. We then break it down to say what this domain includes and what are the areas that we should be focusing on. And really, it's about what matters in practice. But what matters in practice is about what consumers have said matters in practice. We also highlight priorities that we, as Safer Care, are committed to implementing, priorities that are connected to the Department of Health and Human Services, and we also have peppered it with comments and the voice of people who contributed to the consultation. What the importance of that in terms of showing the connection between all of these, the department, Safer Care, communities, the public, the Victorian public, has been a really important and an important thing to showcase, but it also is where it gives the document strength, because interestingly enough, when we looked at the data, we found that there was much more in common between health professionals and consumers. So the areas of priority, the areas of significance, the areas of challenge, the areas of improvement were all very much connected. So there were many, many synergies rather than lots of points of difference. And that was a really interesting finding. This is just a snapshot of the equity and inclusion domain, and it talks about, what priorities are there for Safer Care, but importantly on the left you'll see each domain has a list of priorities for health services, so for hospitals. So this gives hospitals a checklist to say these are the top priorities identified from the consultation, and we suggest that you think about how you're going to implement them. Just very quickly, and I think I'm just making sure I quickly run out of time, I just wanted to highlight a couple of very quick examples from each of the domains. I'm not going to read out all of these for you, but One of the most important things that we're trying to support health services to do is to recruit, develop and support consumer leaders. So we have a model ourselves. We are very proud of the fact that we're putting that model into practice, and we're modelling good behaviour that we want to see in other health services. And we're actually developing now a model that we will share with health services across the state. So we shouldn't be the only ones that employ consumers. Some health services are, but we want to see that much more across the state. One of the other areas is adapting particular strategies around the Patient Activation Measure, or PAM, which is from the UK, to support consumers in their healthcare. So each domain, each time we're looking at what kinds of interventions and strategies are actually practically going to work. So if we look at working together, we've got some of the things that we're supporting currently are things like how we develop practical tools and strategies to improve collaboration and engagement among consumers, families and health professionals. One of the programs that we're initiating is called the Collaborative Pairs Program. This links a consumer or a service user with a clinician, and they explore how to work collaboratively together across the organisation for improvement purposes. I'm just going through these very, very quickly. Shared decision making. One of the things that we're doing in this space is that we have a partnership with Professor Dawn Stacey from Ottawa in Canada, who has worked in the shared decision making space for a long period of time. We want to see shared decision making interventions practically become part of routine clinical practice, so that consumers or service users are clear when a decision is being made and what that decision is, how they can make that decision, what are the risks, what are the benefits of that decision, and they have at their fingertips the information they need and advice to actually be able to make an informed decision about what's best for them. This is just a very quick example of the Ottawa Personal Decision Guide. Currently we've got a small pilot of 8 health services, small rural health services who are very small, metropolitan health services and regional health services who are looking at where and how to adapt shared decision-making interventions, some in a specific clinical situation, such as stroke clinics with stroke patients, or in adapting a general personal decision guide that they can use with their entire population if they're a very small rural health service. So equity and inclusion, of course, some of the things that will be familiar to all of you around ensuring accredited interpreters are provided when needed, looking at the budgetary implications of that, as Karima has mentioned, which is always an ongoing challenge with ever-increasing demand and ever-depleting resources. We also we are piloting and encouraging and working with health services to look at cultural safety training mechanisms across all health services, and there are a number of pilots in that space. One of the things that we also are very clear about is that how do we actually ensure diverse consumer engagement, or diverse consumers are involved not only at the direct care but the service and the system levels. So we're developing with a specialised agency some guidance and tools to help health services employ different types of consultation strategies and connecting strategies with consumers. Finally, effective communication. One of the things that we're looking at here is developing a consumer-focused model for teachback, looking at Ask Me 3 or Asking the Right Questions Matters. They're all individual pilots and different initiatives in health services as well. Also, we're doing a pilot called Your Thoughts Matter with another university, so in partnership with the university, which is a whole of organisation approach to providing educational training opportunities for both clinical and non-clinical staff within hospitals in terms of improving communication to therefore improve person-centred care and enable clinicians to provide personalised and holistic care. We've asked health services to tell us what domains they're working on. So as of the 30th of June, 90% of public hospitals have identified which 2 domains they're working on. And this graph represents those. So the most popular, of course, is effective communication, because that is one of the consistent and persistent challenges in healthcare. Communication breakdowns are at the root of all evil, basically. Working together was the second one, equity and inclusion the third, personalised and holistic, a challenge, only 21, and shared decision making, only 21. But this represents a snapshot of what health services are focusing on in Victoria. We haven't said that this framework is mandatory, but we've said it's required. So we were very pleased that 90% said this is what they're doing over the next year. Two of our strategic objectives of the branch that I work in, which is called Consumers as Partners, is very much that consumer voices and choices are central to their own care. And so this just merely represents the targets that we've set ourselves as an organisation for improvement and measuring our progress as we roll out the Partnering in Healthcare framework. So basically we want 100% of health services to report against their progress against those identified priorities. Next year in May, we have an outcome summit planned. So this is a gathering of health services. We didn't want them to write us a report. They have 1 million reports, they have 1 million plans, they have very many accountability mechanisms. So we decided that we'd go against the grain and we just get people together in a room to share what their story has been. What is their practice? What were the challenges? What were the insights in terms of implementing these domains? That will then be recorded and captured as a document that represents where health services are at and their progress over that year. A couple of the other things that we're focusing on too are getting more consumer representatives, which I've mentioned. And very, very quickly, the second strategic objective is consumer voices and experiences improve health services and the health system. So this is actually about consumer engagement for the purposes of healthcare improvement. So one of the trials that we have, which I did mention under the communication domain, was that we have a trial called Hear Me, which is a patient escalation project, which is being trialled across 17 health services. And that's where patients or service users or consumers are in a situation where they feel they are not being heard by clinicians or health professionals. There is a mechanism to actually utilise a report, an on-call mechanism to say, I've tried, but I haven't been listened to, or they're not taking into account my concerns. And of course, like anything, most of these things come from terrible experiences that should not be repeated again. And in this instance, in Australia, there's a rule called Ryan's Rule, and that was created because, unfortunately, a young little boy died because his parents were not listened to sufficiently and in a timely way for his condition to actually be rectified. So these represent really just some of the types of measures that we are holding ourselves accountable to. And because I'm running out of time, I won't go into all of those. We've got also very quickly a couple of tools. We're consistently developing tools for health services. A self-assessment tool around the 5 domains, the 3 different levels, and asking health services to tell us what they're doing, but giving them an opportunity to reflect on how they're actually how do they actually identify which are the priorities in their health service and what needs to improve. We also have tools that connect what the 5 domains are to the national accreditation standards. So this is about trying to make it easier for health services to see that what they're doing in the Partnering in Healthcare framework enables them to actually connect and achieve their accreditation results. So very practical. And that's all I have time for, and happily answer any questions. Thank you very much.
Thank you very much, Lydia. I think very interesting the whole consumer involvement, which is something that in Belgium, especially for ethnic minorities, I think is very, very limited.